So whether you're a parent, a caregiver, or someone who cares deeply about the well-being of their child, this episode is for you. We'll be sharing valuable insights about how the fracture happens in the upper limb, the different types of fractures, and also what to do when fracture happens. Today we have with us Dr. Sadaf, who is a pediatric bone specialist and an orthopedic surgeon. Welcome, Dr. Sadaf.
Thank you very much for the invite, Dr. OWAIS. And as always, it's my pleasure to be here on the show with you and to be a part of this very noble initiative of yours where you're trying to spread awareness for the well-being of the children and their safety.
Pleasure is all mine, Dr. Sadaf. So to start off, what is the most common fracture that occur in the upper limb?
Well, let me ask you a question. Your question is with a question. Subconsciously, if you're falling, what's the first thing you're going to do?
Well, I would try to protect my body and automatically I'm going to stretch my arms.
You got it. So the most common mechanism by which an upper limb fracture can happen in children is fall on an outstretched hand. Because the moment any child is falling, the first thing their brain wants to do is to break the fall. And to break the fall, they're going to fall on the wrist, trying to put all of their pressure onto the wrist. And depending upon the force of mechanism, a particular fracture pattern can be predicted.
So, Dr. Sadaf, does this imply that we can predict the mechanism of fracture?
Yes, absolutely. Not to 100%, not completely, but more or less, the fractures happen in a predictable manner.
So, Dr. Sadaf, what do you mean that a person falling from a higher level of height than someone who's falling from a lower level of height, you will be able to predict the mechanism of injury in that case?
The intensity of a fall and the mechanism of injury are the basic determinants of a particular fracture pattern. Like you have rightly mentioned, if somebody who falls from a higher height would have a different fracture pattern in terms of the number of bone pieces that we are seeing in a particular fracture, by which I mean that the bone might be broken into more than one pieces or in more than one places when it comes to a fall from a higher intensity. Then when it is compared to a lower intensity fall where we expect that the bone will be broken in a simpler fracture pattern and in only one piece.
So, Dr. Sadaf, now whether it's a complex fracture or a simple fracture, let's say if it's a single break in the bone or let's say if it's multiple breaks in the bone, how do the management differ in terms of as orthopedic surgery is concerned?
The initial management of whether you're dealing with a complex fracture or whether you're dealing with a simpler fracture pattern is the same, and it is providing analgesia to the child, because what we need to do is to make the child comfortable, and the child will be comfortable only once the pain is gone. So analgesia, strong analgesia is the foremost thing, whether you're dealing with an open fracture, whether you're dealing with a comminuted fracture, a simpler fracture pattern, or whatsoever. The second important thing is to splint the fracture. So like I previously mentioned, any fracture pattern that you're dealing with, these two things are of utmost importance: analgesia and splintage. After that, the further management course depends upon what sort of a fracture you're dealing with.
So, Dr. Sadaf, now you mentioned a lot of types of fractures in here, namely open fracture, comminuted fracture, compound fractures. Like, what do you mean by all of these terms? If you could clarify those as well.
Well, these are different types of fracture patterns.
Okay.
Fracture is like a broad terminology, which means any break in the bone.
Sure.
Then we have different types. For example, let's say if a bone is broken only at two different places, then it's a simpler fracture pattern, as the name implies. Comminuted is if the bone is broken in more than one piece. So it's with a higher intensity of energy. Then there is a term called as an open fracture, where there is a wound. And then we have closed fractures, which are without any open wounds.
Okay, so now this comes to an interesting discussion here that let's say you had an open wound fracture where you have bones sticking out versus you have a fracture where you can't see from outside the skin and all you see is the child has fallen and there's a big swelling in the arm. What do you do to manage that condition in both situations? For example, an open fracture, what would you advise for parents to do at that particular point in time? And let's say for someone we're having a big swelling in the arm, but he's not sure whether there's a fracture underneath or not at the playground, most probably. How does the parent deal with those situations?
The first and foremost advice, don't panic.
Right, absolutely. Don't panic.
That's the first thing. Now, let's take each scenario bit by bit. In case you notice that the child is having a swelling and there's no open wounds or there's only minimal bruising, the first thing to do is to take the patient to the nearest health center or nearest hospital facility and get an x-rays to make sure that there is no bone that is broken. Because many times you will have fractures without any swelling or you will have swelling without any fractures. Right. So it is quite possible to have a huge swelling but no fractures.
Right.
And then let's take up the other scenario where a child has broken up a bone and you see an open wound and there is blood that is coming out from there, or there is a piece of bone that is sticking. So if there is any piece of bone that is sticking outside, kindly do not make an attempt to keep that bone inside the skin. Just bring the child to the nearest tertiary hospital or nearest medical facility as soon as possible.
All right. Now, like you mentioned, do not play with the bone that comes out of the skin. Do not try to push it back in. But if there's a lot of bleeding, do you advise to kind of wrap it up and cover it and then probably keep the limb immobile or kind of splint it as well at that particular point?
Yes. Just be careful as to not apply a lot of pressure so that the circulation of the particular limb is not compromised.
Right. That's very important.
Just appropriate point pressure if possible. And if it's not possible to provide point pressure, then an appropriately pressurized bandage. Not too much pressure, not too loose. Just enough pressure to stop the bleeding.
Thank you, Dr. Sadaf. That's great advice. Now, Dr. Sadaf, the child has arrived at the hospital, has received analgesia, has an x-ray done, which kind of shows he has an obvious fracture in the upper limb. What's the definitive management there?
Definitive management is always governed by the degree of displacement.
Okay.
You need to know what's the degree of displacement in order to know whether you're going to treat this particular fracture in a closed manner or this would require an operative fixation.
Now, Dr. Dev, you mentioned the word displacement. Can you please explain it to our viewers? What is displacement?
Displacement refers to the amount that the bone has moved from its original position. Now, a displacement can be a complete displacement or it can just be an angulation for that matter. Now, in children, and specifically only in children, there is an amount of displacement that can be tolerated by each bone, which means that you don't necessarily have to place the bone completely in line like a ruler or like a scale. There is a degree of tolerance to each bone depending upon the age, depending upon the angulation, depending upon the displacement, where you can leave a degree of displacement and it will remodel as the child grows.
So what you mean to say is that a little bit of curve or a little bit of deviation from the main position, it will revert back to its main position over time.
Exactly. And this is something that is unique and that is given to the children by nature.
Now, Dr. Dev, what is the most common type of upper limb fractures you usually see in your clinical experience?
In decreasing order, the most common fracture is the distal radius fracture, and it makes sense. So the first thing that hits the ground and takes the brunt of the energy is your distal radius, followed by supracondylar fractures of the humerus, both bone fractures, and proximal humerus fractures.
Wow, so just for our viewers, there are 3 big bones in your upper limb. So we've got the humerus, that we call humerus, the one in the shoulder, and then you've got 2 bones in the forearm, the radius and the ulna. Am I correct, Dr. Sadaf?
Yeah, absolutely.
And then the fracture, the most common fracture that we're talking about is the distal radius fracture, which is about at the level of the wrist.
Exactly. Let me clarify this further, Dr. OWAIS, that each bone, each long bone has a lower end and an upper end.
Right.
The lower end is called as the distal end. So during further down the discussion, we would be using terminology such as the distal radius or a proximal radius or a proximal humerus. Proximal is the terminology that refers to the upper end of the bone.
Right.
And then there is a terminology called as a shaft, which is the middle area of the bone that's between the upper and the lower end.
Right. So the most common area would be the distal radius. And what would be the second most common? Would it be the middle of the bone? I'd imagine, because the force would be traveling this way, then either this is the first one to break, and then the shaft would be the next one to break, and then followed by an elbow, and then followed by a humerus. Is that how it works?
Technically, it should work this way, but that's not the most common pattern types.
Okay.
The distal radius fracture is the most common type, followed by the supracondylar fracture of the humerus, which is basically around the elbow region.
Right. So supracondylar fractures are the second most common that you see coming for treatment.
Yes.
Now, Dr. Sadaf, you mentioned supracondylar fracture. Now, I've heard this term, and the way I remember it, especially in the middle of the night when I'm on call, I receive a call from the orthopedic surgeon saying that there is a child in the emergency department who has sustained a supracondylar fracture. And I always think, why does it happen in the middle of the night? And why do we have to fix it in the middle of the night?
Only an anesthetist could have asked this question. Why in the middle of the night?
Yes, strange. I mean, the child should have been asleep during that time, but then he's in the ER and the parents are quite anxious and stressed, and sadly he's broken his arm.
Okay, so let me break this question into two. Firstly, why supracondylar fractures occur only in the middle of the night or when the child is asleep? Because the most common mechanism by which the supracondylar fracture happens is when the child falls over his elbow.
Right.
So, a child is asleep, accidentally rolls over and falls on the ground with his elbow, and that's how they break the supracondylar region of the humerus. Secondly, why are we so stressed about a supracondylar fracture as orthopedicians? Trust me, one fracture in upper limb that stresses all the orthopedicians is the supracondylar fracture, because it is the fracture that is associated most commonly with neurovascular implications. By neurovascular implications, I mean that there is a vessel that goes over that region, over the supracondylar region, and supplies the whole arm. So, in case you have a badly displaced fracture of the supracondylar region, it can kink or even in certain circumstances lacerate that blood vessel, which might ultimately lead to a compromise in the vascularity of the rest of the arm.
Right. And I've seen many times that the orthopedic surgeons are always trying to feel the pulse down the arm and to look for a pulse to make sure that the vascularity or there's enough blood supply down the arm, right?
Yes, and that too specifically in a supracondylar fracture. Also, these sort of fractures can be associated with neurological injury. Neurological injury, most of the time, is just a stretching of the nerve that passes through the same region, and most of the time, it just reverts back to normal within 6 to 8 weeks. It's just a stretch, neuropraxia most of the time. But in cases of the vessel, it can be a laceration or it can just be a stretch. So we have to be careful around that and vigilant to see and to pick up that abnormality.
So parents, it's so important that if this happens to your child in the middle of the night, that he falls off the bed and there's a huge swelling in the arm, or he's complaining of severe pain in the arm, I believe you should rush your child to the hospital to get him checked out if he doesn't have a supracondylar fracture. Now, Dr. Sadaf, coming back to the most common type of fractures in upper limb called the distal radius fractures. How do you manage those fractures? Do we need to operate them?
A good point to distal radius fractures, despite them being the most common type of fractures, 90% of the chances are that the distal radius fractures can be managed conservatively.
It's reassuring.
Isn't it? But when I say conservatively means manipulation with a cast or only a cast. Sometimes if it's not displaced to a greater extent, then just a well-molded cast would suffice for around 4 to 6 weeks, and that would be it. But in case where the displacement requires a little bit of manipulation, we usually do them under sedation in the emergency or under anesthesia in the operating theaters. And once we have brought the bone back to its position, it's just kept in a cast in a similar pattern for 4 to 6 weeks. Occasionally, we need to operate on to a distal radius fracture. Why so? Is because in case it's an unstable fracture pattern, we do not want it to move post manipulation, and we just hold it with a simple implant called as a K-wire that comes out in the outpatient settings within 4 to 6 weeks once the radiographs during follow-up have shown.
So manipulation under anesthesia, yes, I've done those cases in the OR as well, and it's simply just trying to pull and push and try to bring the bone back into its original position, right, without making an incision or using a blade. And we do it because it's very painful to do it, so we provide a little bit of painkillers and sedation and anesthesia so that it's done in a very comfortable manner. And I think you do use x-rays to make sure that the bone is aligned in the right position. Am I correct?
Yes. Acceptable position is the terminology that I would use.
Acceptable. So it doesn't have to be exactly where it's supposed to be, but the closest it can get to that position.
True. Functional position. Because at the end of the day, functionality is what is more important. And what we are looking for. It's not the radiographs. It's not the beauty of the bone on a radiograph. It's the functionality of the bone that matters.
Now, Dr. Sadaf, is it common to break both bones in the forearm?
Well, there is something called as a both bone shaft fracture.
Okay.
Where you tend to break the shaft or the middle portion of both radius and ulna together.
That's very interesting.
And the management is completely different when it comes to the shaft fractures as compared to the proximal end or the distal end of a particular bone. Now, the shaft of any bone tolerates a less degree of displacement as compared to the upper end or the lower end. And the reason being is that the upper and the lower end of the long bones is the position from where the bone grows. So this portion of the bone being nearer to the growth plates tolerate a higher degree of displacement and remodels more quickly because more bone is being produced through the growth plates. Whereas the further away that you go from the growth plate, the lesser the degree of tolerance of displacement. This has an implication when it comes to the management of both bones, which means that they more often require manipulation, they more often require open reduction, and they are more often taken to the OR for further management.
Now, Dr. Sadaf, you mentioned that these fractures of the shaft or the double bone fractures, both bone fractures, need to be taken to the OR more frequently. Now, what differs in their management as compared to other fractures?
The type of implants, the type of cast that they have put, and the time duration that these bones take to heal is entirely different.
Okay.
Let's take them bit by bit. The implants. When it comes to an implant fixation, the distal radius fractures most often use an implant which is called as a K-wire. Now, that K-wire is placed partly inside the bone and partly outside the bone. And it is taken within 4 to 6 weeks depending upon post-operatively how the fracture is healing. And during outpatient follow-ups, regular radiographs are done, and then as per the radiographs, we can decide on to 4 weeks is enough or 6 weeks is enough. As compared to that, the duration of treatment for a both bone fracture is around 6 weeks.
6 weeks, that's a huge difference from distal radius fracture, although this is getting an implant as well.
Yes, because it is further away from the growth plate, so it takes a while for them to solidify.
Right.
And the implant that has been kept usually for a both bone fracture is something which is called as a flexible nail, and this is completely inside the bone, which implies that to take it out, you need a complete anesthesia, and they are taken out within 4 to 6 months rather than 4 to 6 weeks in comparison to the distal radius fractures.
So what I understand is you'll be a little bit unlucky if you get a fracture of the shaft or you get both bone fractures, because the management is also quite lengthy and complex, since you have to go to the OR and you have to go under the knife twice, once to get a nail in and then another one to get it out, and over a period of 6 months the nail stays inside the body, right?
4 to 6 months. Usually we try to take them out within 4 months, but in case of delay sometimes, or in case the fracture doesn't appropriately solidify within 4 months, they are taken down within 6 months. And also the cast. The cast that is used is an above elbow cast for the treatment of a both bone fracture as compared to a below elbow cast for an isolated distal radius fracture.
Wow, so not all fractures get the same cast for the upper limb. Different fractures get different types of cast, different lengths of cast, and different sizes of cast, right?
That's absolutely true.
So, Dr. Sadaf, when it comes to managing cast at home, what advice would you give to parents?
Whether it is home or whether it is the wards or the inpatient settings, post-operatively, one very important thing that need to be noticed is the swelling. This is something that we dread.
Right.
Swelling is something that should be avoided at all costs, because especially if a full cast is applied, the swelling is going to make the cast tight, and once the cast is tight, the pressure, there is no way for the pressure to dissipate. So what happens is that the pressure causes the muscles to start dying or start necrosing because of that enclosed cast that is there. So
right.
If your child complains of pain and the pain is not relieved by analgesia, or you notice the fingers to be swollen, or your child is complaining of the cast being tight, then this is an indirect sign that the cast needs to be split open.
Right, and discoloration of hands or arms is also one of those signs, right?
Yes, absolutely, but that is a late sign, so you would not want to wait until the fingers swell to an extent where they become discolored or they become cold or they become pale. Before that, you should take an action. So, while at home you notice that a child is complaining of pain and you're giving them regular analgesia and the pain is not subsiding, or you notice that the fingers is swollen, or the child itself is complaining of the cast being uncomfortable, kindly bring the child immediately to the emergency settings so that the cast can be halved and the pressure can be relieved.
So, Dr. Dev, are there any steps that you can take at home to reduce or to avoid swelling when you have a cast?
Absolutely. Elevation is foremost importance. So you need to keep the arm, the operated limb elevated. It should be above the heart level so that all the swelling just goes down.
Right. Makes sense. And how often do you recommend should we elevate the arm above the heart?
It should be kept elevated, especially within the first 24 to 48 hours, where the swelling has a higher chances of setting in.
Great advice. It's been an eye-opener. What a great episode, and I've learned so much about how to manage fractures in upper limb in children. So, Dr. Sadaf, is there any last thoughts you would like to share with our viewers today?
Absolutely. There are some important advices that comes into play when we are speaking about the upper limb fractures. Firstly, any child who sustains a fall, has a swelling, complaining of pain without any swelling, should be taken up to a medical facility and get a radiograph done. Okay. It might be that patient doesn't have any fractures. It might be that he has sustained comminuted fractures, and it might be that the swelling is without a fracture. So avoid massaging the area. Take them to a formal medical facility, get the plain radiographs done. A second important thing is that every fracture has an individualized management. Parents, children will break their bones. It's a part of growth process. Please do not blame yourselves for them having a fracture. Don't consider that if you were there to supervise them, such fractures would not have happened. A child can break the bone by falling in any particular way and in any particular mean. So I would not say it's okay to have a fracture, but yes, you can consider it a part of normal growing process.
Absolutely right. And most importantly, the most common type of fractures in children are usually mostly managed conservatively rather than surgically.
So parents, let your children have fun. Let them enjoy their childhood. It's good to be safe, but at the same time, it's important for them to enjoy their childhood.
Well, that's it for today. I hope you found this video valuable. For more information, you can visit our website, drwaisrafiq.com. Till then,
Inspiring hope.
guiding health, one heart at a time.